All right, welcome to today's discussion, Driving Health Research Forward with Mortality Data. Thank you all so much for joining us today. And I'm going to go ahead and start by introducing myself first. My name is Rachel Connolly. I have been with Merative and previous organizations that now comprise Merative for the last 15 years. I have been focused on the data and analytics space, working across a variety of different parts of the healthcare spectrum, largely looking at different ways that we can improve population health. My current role is part of the product management team here at Merative that is focused on MarketScan, which is the longest running closed claims data set on the market. With MarketScan, we support a wide range of healthcare and research organizations who are working with the data on regulatory processes. They're driving epidemiological research and health economics and outcomes research. Our MarketScan research databases offer research-grade data, but it's data that is uniquely sourced from self-insured employers, health plans, and state Medicaid organizations so that we can bring to our researchers and bring to our users a complete and longitudinal picture of care to help advance their research objectives. The family of MarketScan research databases together offer insight across multiple players, so you can analyze commercial, Medicare, and Medicaid populations, and through our unique sourcing and pulling information from self-insured employers, we can get deep into the details of actual cost, we can help analyze clinical outcomes, employee productivity impacts, and much more. Real-world data, including databases like MarketScan, have played a critical role in informing treatment guidelines and in improving patient outcomes. However, for us to truly advance population health, we need to be able to understand mortality. And despite mortality being one of the most subjectively measurable endpoints in research, finding quality research-grade mortality data can be a challenge. Today, we have two really great speakers joining us to share their experiences and explore how we can advance research with mortality data. And Scott, would you like to kick us off and tell us a little bit about yourself and your organization?
Sure, Rachel. I'm a public health economist and health services researcher at the Centers for Disease Control and Prevention, where I've worked since 1996. I have my academic training in economics, demography, and epidemiology. I have co-authored roughly 50 analyses of MarketScan data over the past 2 decades. I work at the National Center on Birth Defects and Developmental Disabilities, which is the part of CDC that focuses on disabling childhood onset conditions, for the most part, such as birth defects, rare diseases, and neurodevelopmental disorders such as ADHD and autism. CDC assesses the health status of people living with such conditions and seeks to help optimize outcomes and health equity.
Awesome. Thank you, Scott. And Ori, would you like to introduce yourself as well?
Absolutely. Thank you so much, Rachel. Hello, everyone. Glad to see you all at this webinar. My name is Uriel Feodejude, and I'm a hematologic oncologist at Dana-Farber Cancer Institute, where I specifically focus on the care of patients with lymphoid malignancies, which is the most common type of blood cancers. I'm also a health services researcher within the Division of Population Sciences at Dana-Farber Cancer Institute. My research lab focuses on characterizing the quality of care, patterns of care, and developing interventions to improve care for patients with blood cancers throughout their disease trajectory, particularly near the end of life. So some of my work has focused on characterizing the quality of care that patients receive based on national metrics that are approved for end-of-life care. I've also been working to understand the impact of insurance type on the equitable provision of high quality care near the end of life. So I'm excited to speak more today about the value of having mortality data for the kind of work I do.
Yeah, thank you. You both have such extensive backgrounds and experience, and I'm looking forward to the discussion. And Ori, do you mind kicking us off? Let's go into our first question. Can you talk through your perspective on what is the value of having access to mortality information for your research?
Thanks, Rachel. I think it's so crucial to have mortality data for my research, particularly the research that's focused on end-of-life care. And I also want to emphasize that even beyond end-of-life care, mortality data is crucial. And three key things that I think of about sort of the value of mortality data is, first of all, one, to actually identify a decedent cohort. So a lot of the research studies I've done looking at end-of-life care, I've been working on patients that died of their blood cancers or died with blood cancers. And knowing that it sounds simple, knowing that a patient died, but when you're working with claims data, if someone disappears from the claims data set, is it because they changed insurance type or is it because they died? So being able to really know that someone is dead to identify a decedent cohort is very valuable for in terms of getting mortality data so that we're not misclassifying the population that we're actually conducting analysis on. So without identifying a decedent cohort, it's literally it's almost impossible to do sort of good high quality research when you're assessing the end of life space. And then the other value of that I think of when I think of access to mortality information is having the date of death. It might be very precise, the exact date of death, or it could be month and year of death. And that is critical when we're sort of looking at what are the metrics of what kind of care people receive near the end of life. So some of the work I've done, we've looked at national metrics like are patient overutilizing high intensity care in the last month of life? Are they having multiple hospitalizations, being admitted to the intensive care unit, multiple emergency department visits, or receiving chemotherapy in the last 14 days of life? And for those kind of analysis, the anchor or the index point is the date of death. Without knowing the date of death, then it's hard to sort of assess end of life care within a period. That also goes to health economics when we're looking at the cost of care near the end of life without being able to anchor it to the date of death, that becomes a challenge. And so having those kind of mortality data can be very valuable. And then the third thing that I will mention is also thinking about the cause of death. This is not necessarily a piece that is needed for every type of analysis, but when we think about analysis where cause-specific mortality is the outcome, that becomes critical in mortality data. So some of the work that I've done has looked at sort of lymphoma-specific survival. And to be able to look at that, having a sense of did the patient die because of their lymphoma or did they die because of other reasons can be very important. So the value of having mortality data is really extensive. And again, I just want to emphasize, even though I do a lot of work on the end of life phase, the data also important beyond that, because when we think about studies looking at impact of upstream factors on survival, so survival is the flip of mortality. To be able to assess that, you also need mortality data. So there's some work that my lab has done looking at mental health disorders around the time of diagnosis of certain types of blood cancers and looking at the impact that has on survival. So having the mortality data, knowing when people died, the duration of survival was also very important to be able to address those primary outcomes. So again, mortality data is very valuable for health services research.
Yeah, thank you. It seems to play a significant role in your ability to advance your research efforts. Scott, do you want to share a little bit more about your perspective on the value of mortality in your research?
Sure. The challenge for me is I rarely have the mortality data that I would like to have. Because what I'm usually doing is working on analyzing policy questions. My primary research area is newborn screening, analyzing what is the expected health impact of introducing a policy to screen all newborns for a given condition. And that requires projecting survival with screening and without screening. So you need a comparator. And so finding the data for the comparator group as well as those who've had the intervention is very challenging. When we do prospective studies, the follow-up period is usually too short to collect much useful information about survival. So we rely on historical data, clinical data, and try to piece that together. So it's challenging. But if you don't have information on survival, how can you assess life years or quality adjusted life years to assess the benefit of your intervention?
Is there anything else that you've found, Scott, to be challenging when trying to find and use mortality information? Um, we can continue going on that path.
Very much so. One of the challenges, which Lori's already mentioned, is that the mortality data and vital records reflect causes of death that are listed on death certificates, which are often inaccurate or insensitive. We did a study once using linked data with New York State, where they linked the data from vital records with newborn screening program data, where we knew exactly who had sickle cell disease, and looked at deaths up to 10 years of age. And we found a lot of the deaths were not recorded in, the deaths were recorded in vital records, but they didn't have sickle cell listed as a cause of death. And so if you're trying to estimate survival of a cohort, it's really important to have complete data. Administrative and clinical databases are also often insensitive, not capturing deaths that occur outside of clinical settings. And so when you use those data to estimate survival rates, you can get misleading estimates. And as I mentioned, it's particularly difficult to estimate mortality for comparator groups. But whether it's an intervention group or a comparator group, you have to be aware of multiple sources of bias, including spectrum bias, which is that because most conditions involve a spectrum of severity, and it's related to ascertainment referral bias, that your comparator group may have overrepresentation of relatively severe cases. And then there's also left truncation and mortal time bias. So that New York study that I mentioned, turns out we could not reliably estimate neonatal infant mortality because the diagnosis of sickle cell disease typically occurs at a week or so of age, and the majority of all neonatal deaths occur in the first day or two of life. So researchers who don't take into account the left truncation bias are likely to calculate that infant mortality for children with sickle cell disease is lower than for other children, which is actually what we found when we first did the analysis, but we said that can't be true, so we went back and figured out what the issue was. So, yeah, very tricky.
Ori, have you experienced some of the same challenges in finding and using mortality data?
Yes, very similar challenges. I think, one of the challenges with finding data is sort of what data set are you using, right? So when we think about trying to use electronic health records, local data sets, because the healthcare system, people can receive care in different settings, which may not all pull into the same electronic healthcare record. So the fact that someone in an electronic health record was last seen alive on this date, you don't know whether they're dead or they've transferred care or they've moved location. So it can be hard to find those sort of the mortality data. And in those settings, you have to think about, are there ways to sort of link to national data to have, a sense of who is alive, who is dead. But then that requires several steps. We don't just have immediate access to national data. So there's a certain amount of work that has to be done to get that. There's also sort of the thinking about linking data sets to mortality data, even when we have access to the National Death Index. What are the data sets that we have available to answer the kind of questions that we need? So I've done large population based analysis. Some of those analyses have been limited by sort of the data that I have available, which is focused on people that are insured or people that are 65 years or older. So there are times when I have questions that could pertain to a younger population. So some of sort of the data sets that we have to link can also be challenging, sort of finding the right data sets. And then when we also think about sort of linking data to mortality information, I think just as Scott said, thinking about the limitations of what we do, because every method has some limitations. So while we have cause of data, understanding how those causes get written on a death certificate, and when someone has multiple conditions, which one is placed as the primary condition or the cause of death, can really help in terms of thinking about analysis. So there are challenges, there are limitations which have to be accounted for in the way the findings of the research are interpreted.
And when you're working with linking in mortality data and managing those limitations, how important is it to have that linkage and the mortality data at the same time where you can get a full view of the adjudicated claims? Does that help you with your interpretation and handling those limitations?
Yeah, so having sort of broad data can be very helpful, and also sort of when we're sort of creating or our cohort assembling, understanding why certain folks are dropping out of the cohort, so that we're understanding whether the final cohort creation has biases that we have to address in the interpretation of our findings. It's very important. So are there biases in sort of who is dropping out of the cohort, who we don't have enough data to link to the national death index, things like that? I think those have to be considered in the cohort creation. And are we losing a huge chunk of sort of our cohort by the time we like slim down all our criteria to be able to link the data? I think those things are very important, especially when we put out publications and the transparency of how did we arrive at our final cohort.
Have you had a similar experience, Scott, with linking with mortality information?
I've limited experience actually using those linked data. I think it's a great idea, but it's challenging in practice. And one of the challenges is that the linking depends on the identifiable information. One of the issues that I've seen discussed in the literature is that individuals who have are in marginalized groups are less likely to be linked for various reasons. And so using those linked data does not give you necessarily an unbiased source of information for estimating mortality, because the individuals who are not linked may actually be at greater risk of mortality. Ori, do you want to comment on that?
I think that's a great point that you bring up. When the process of an analysis now, those were I don't have like the answer to the question, but those were the things that, as research groups were like, who are the people that we don't have data to submit for linkage? Like, is there something systematically different, about those people? And I think when possible and when there are resources available, if there are ways to sort of do some sensitivity analysis to figure out, while some of the claims data may not have the granularity of knowing people's race or ethnicity because it's claims based, but do we have data about sort of the area where people live, where we can sort of say, are there systematic differences between the people that we have enough data to link versus those that we don't have enough data to link?
Yeah, that makes sense. Are there other considerations that you would want to share with our audience today on how you might overcome some of those limitations and the instances where finding death data for the population you're working with is much more challenging?
The more sources of information you have, the better.
Yeah. And one of the things that we often try to do is thinking about sensitivity analysis to sort of answer those questions about bias. And another thing that I've done, which is not that I advise people to necessarily do this because it's a lot of work, is some of the work that we're doing with like population-based data. Some of those analyses we're replicating in our sort of institutional data where we have more granular details, where we can sort of figure out what actually happened in the clinical care, where we're not just relying on claims data to sort of say, are we arriving at, similar conclusions? Obviously, the context is different, that there's a different region versus the national data, but sort of getting a sense that when we have more granular data, are we sort of are the data aligned, or are there like big differences that we should pay attention to?
It makes sense.
I totally agree with your suggestion of sensitivity analysis. That's really important. It's not just with claims data. Like if you're using survey data, you should always be aware of potential non-response bias and do sensitivity analyses. And same thing with potential confounding. There are so many threats to validity when using real-world data that being sensitive to those threats is really helpful.
And I'm assuming that the systematic bias in terms of who can and can't be linked depends a lot on the data sourcing as well, as we've been discussing. Are there certain sources that you can think of that would be better in that respect from others?
It's challenging because I've not necessarily like compared, different sources. So while it's hard to explain that, I think knowing what source you're using and knowing the limitations. So for instance, you can link claims data to National Death Index. There are population-based registries that are linked to claims data. There are also some other data sources that are hospital-based, so they're not population-based. So when I sort of do research or also read papers, I'm thinking about the context of the data source. So for instance, some of the hospital-based registries that are linked to claims data and then mortality data, one of the things to consider is that they are based on facility and not individual based. It's sort of what's happening in different hospitals that are collated together versus when looking at data or doing research with population-based registry data that is linked to claims data. So I think it's sort of less about comparing which one is better than the other, but sort of each data set has its own inherent strengths and weaknesses and understanding those. And some data sets may be better for a particular research question, even though they have their weaknesses just because of the question you're trying to answer. So if a question is more focused on sort of hospital care, surgery in the hospital, maybe the hospital-based data set with claims linked to mortality data may be more effective for that question. So I think just think about what's my research question and what's the data source that may be best suited for the research question.
And also there are going to be trade-offs that some health systems may provide higher quality data, more granular data, but they may be not representative of the population, whereas population level databases are more representative but may have less granular or rich data.
Yeah, that makes sense. I wonder for a moment, let's go back to the value of your research, and can you describe for us how understanding the impact to mortality or the impact to survival influences the messaging that you prepare for the different stakeholders that you work with across your research?
Sure, I'll give you one example. 2 decades ago, CDC collaborated with the Cystic Fibrosis Foundation to try to inform policymakers on whether cystic fibrosis should be added to newborn screening panels, which in this country was, I think, last state added probably in 2010. But there are a lot of questions. What is the magnitude of the benefit? And one of the sources of benefit is preventing death. And so we used the Cystic Fibrosis Foundation National Patient Registry, which probably has about 90% coverage of that patient population. And they have very good coverage of repeat visits. And so we think the mortality data are fairly complete. But the quality of the data in terms of why they died is not necessarily complete. So we decided to look at all deaths, regardless of the listed cause of death, based on where the child was born. At the time they were born, was that state screening all newborns for cystic fibrosis or not? So we weren't trying to get at were they detected through newborn screening or not. And what we found was children with CF born in states that were screening had about a 2/3 lower risk of dying by the age of 10 years than children born in states that were not screening when they were born. And so that was a fairly persuasive argument for why, yes, states really should offer newborn screening for cystic fibrosis.
Ori, you want to go ahead and comment as well? Yeah.
Yes. Thank you for that great example, Scott. One of the examples I would think about it that I thought about is the work that we've done looking at end-of-life care for patients with blood cancer. So having that mortality data, we did a different analysis looking at patients with different type of blood cancers and found that hospice rates or enrollment rates were lower compared to patients with solid malignancies, and that patients with blood cancers were more likely to die in hospital settings near the end of life. And there was an analysis that I was part of that specifically looked at patients with myelodysplastic syndromes and looked at the patterns of their end-of-life care. And patients with blood cancers, because of their disease and the treatment, often require or need blood transfusions that can help with their quality of life. And what this analysis found was that patients who required transfusions were less likely to enroll in hospice. So they were more likely to die in acute care settings. And having this mortality data and being able to describe this pattern of care was very important for our stakeholders and our national organizations in hematology, because it contributed to the data showing that limited access to transfusion services in hospice settings near the end of life is a potential barrier to timely hospice use for this population. And that has led to advocacy about thinking about how to tailor some of the services provided in hospice to the needs of patients with blood cancers. So having the mortality data to be able to describe what was happening and to be able to identify some of the key potential policy barriers to enrollment and high quality end-of-life care wouldn't have been possible if we actually didn't have data on when people died, where they died, and all those important mortality data.
Yeah, the impact has a lot of reach in the work that you both do. One last question for you, and then we'll open it up to more audience questions as well. Do you have any plans, and can you kind of talk through your plans for how you'll apply mortality to subsequent research, or any additional considerations that you want to share with the organizations listening today around how they should plan for future research in this area?
I'll go first since I'll be brief. I'm planning to retire in December, so I'm not going to discuss any personal research plans, but I am happy to give advice to organizations that it's really important to use linked databases whenever possible rather than standalone data to ensure you have as complete coverage of mortality as possible.
Thank you, Scott, and congratulations on your upcoming retirement plans. So additional work that I'm planning with mortality data, I'm very interested again in understanding end-of-life care for patients with blood cancers, and also understanding sort of policy levers and modifiable barriers to high quality end-of-life care in general for this patient population. But we also know that there are differences in the end-of-life care received by minoritized populations. So trying to think about what are the modifiable policy insurance issues that might influence care. So part of the work that we're currently doing is looking at different insurance types and looking at if there's association with the kind of care that people receive near the end of life. So that's one of the areas of research that I'm working on currently.
And I'm just scanning the questions. There are a few out here around mortality and mortality data in MarketScan. But before I go there, we spent a lot of time talking about the quality of mortality data, the ability to link with the NDI, which is not always something that every researcher has the ability to do. And so I'm curious of your thoughts on how else a researcher could access or use mortality data, the types of pressure testing they might want to do or validation, or even we see a lot of use of death algorithms to help address gaps in mortality data. I'm curious what your thoughts are on how we help organizations when they can't get to the specificity of the NDI.
So there's an alternative to the NDI, which is state vital records. So some of the analysis, like the analysis we did in New York, did not use NDI, used the state death records, because most children remain for the first years of life in the state they were born. So it's not 100%, but I think lots of analysis has suggested that for a relatively short period of time, especially for children, using the state vital record, state death index is good enough.
So I haven't had the privilege of using sort of state vital records, but I have, colleagues that have used that as well. It's challenging when people can't access NDI. Sometimes, institutions sometimes may have linkages of their own that is done on an institutional level where people can then apply for data within the institution. But I guess it depends on people's institution and what resources are available. So, sometimes that is an option. And then there are, some data sets publicly, well, I shouldn't say public where people have to apply for where linkage is already done. But again, people have to think about some of the limitations where it might be like a group of community oncology practices. So how representative that is of the national population, it's, there are those limitations there. So those are, some of the challenges there.
And thank you both for sharing so much about your experience today. I feel like we've all learned a lot around how to consider and think about the bias and limitations and the different ways that you have pulled in and looked at mortality data. I don't see a lot of other questions coming through. I can close with a response around the MarketScan component of this. So we do have the ability to link MarketScan with mortality data, and we do that in a couple of different ways. We have a database that links to the death master file, but also sources from our contributors, inpatient mortality, to have that more rounded picture of capturing death in both the inpatient and the outpatient setting. That is something that we offer as an external file that researchers can use to conduct their own analyses and start getting insights into where they might want to go deeper into mortality research. And then we do, with our services team, have the ability to link to the NDI when that specificity is needed, when you need the cause of death to go deeper from a research perspective. When we provide some materials, and we can provide some materials out to the audience at the end of our call today. But unless there are other questions coming through from the audience, I think we could wrap a little bit early. And thank you so much for sharing your experience, Scott and Ori. It was great to learn more.
Thank you, Rachel. Thank you, Scott.
Thank you,
Thank you. Have a good day.
Bye-bye.
Take care.